Really excited to have you here, Dr. Lara.
Thank you. Thank you. And thank you so much for this amazing setup, Roger. Very professional. I really appreciate it.
Awesome. So let's get into it. Tell me a little bit about your story. Tell me, how did you get into medicine? Where did you go to school? What's the story?
Well, I was born in Maryland, but I grew up in Miami and, eventually went to FIU, Florida International University here in Miami. Eventually went on to University of Virginia for medical school. Then ended up doing a transitional internship at Yale University Hospital St. Raphael in New Haven, Connecticut. I then went on to University of Florida in Gainesville, where I did my ophthalmology residency and retina fellowship for 2 years after the residency. And so then came back, to my hometown, to Miami. I feel very fortunate to have been able to do all that. I was away for 10 years, and every day I'm very happy to be back in Miami. I love Miami. I have seen the growth, from as a kid to, where it was to what it is now. Kind of incredible. But yeah, I started a practice down here, solo practice, specializing in retina. I'm a vitreoretinal surgeon, and we specialize in diseases and surgery of the retina and macula and so forth. And eventually, we started growing and we merged with other practices, and now we're a big group. And so we can provide a lot to our patients, not just from A to Z when it comes to the eyes. So it's kind of one of the things that I really wanted to do down here was sort of build something that was more than just like a single specialty type of thing.
One of the really interesting things that I've learned over interacting with the doctors that we have here at AVG and with all the sub-entities and Retina and Yes, and it's how complex the eye can become and how many different procedures we have. How have you seen that having this big group has benefited the patients that you guys see?
Well, I think it's ideal, for example, if a patient has a disease that you don't treat, for example, like glaucoma or something of that nature, you have somebody that you can reach out to, pick up the phone and have somebody available to you immediately to run anything by them or schedule them into their clinic and get them the care that they need by a subspecialist in their area. And like you mentioned, ophthalmology is very, you would think it's just one eye structure, but it really has, I think there's like 11 or 12 subspecialties within the field of ophthalmology. So it's very diverse, and everybody's got their own niche and their own specialty. And I think that's how, medicine is best treated. Somebody who's a specialist who does that every day kind of can see you and treat you for your particular disease is the best way to do things.
So as you mentioned there's so many different subcategories in ophthalmology, but why did you go into ophthalmology?
Well, I went to medical school to be a plastic surgeon. I thought I liked plastic surgery. And then when I did the ophthalmology rotation, I really fell in love with how diverse the field was. You're able to see patients who are younger, patients who are older, helping people with diseases that can make them blind or blind them, and helping them with that, I thought was incredible. I remember reading a book when I was in medical school, and it stated something like that there's cataract surgeons that actually go to Nepal and would do like 50 cataracts a day for a week. So in the span of a week, they could save 250 people from blindness. And I thought that was very impactful, and it was one of the original reasons I wanted to look into ophthalmology. And then, of course, I went into ophthalmology, loved it, and then also fell in love with the field of retina. It's a field that was at the time that I was there exploding with new therapies and technologies and so forth that I've seen really blossom throughout my career, and has really changed the face of how you treat patients with retinal diseases and the success that you have treating them. Because it used to be a field where a lot of the successes were less than more compared to nowadays. I mean, it's the success rate with injections and so forth for macular degeneration, diabetic retinopathy, to name a few of the big diseases, has been phenomenal and nothing short of miraculous in my opinion. And so it was that sort of burst of development and technology in the field of retina that sort of propelled me into that field.
One of the things I've kind of been learning is we have the eyeball, right? And we have the front, the interior part, and the posterior part. Why for you did you focus so much on the posterior aspect of it?
Well, like I said, the eye is like a camera, and so the front part of the eye, or the focusing mechanism, you have your lens, you have your cornea, and then you also have the film of the camera is equivalent to the retina, and so you can take the best picture possible, but if the film isn't good, you're gonna end up with a bad image, and so again, it was the diseases that were, for example, when I started in retina, we had just gotten in our residency an optical coherence tomography scan. So that's an OCT scanner, and it basically, showed all the layers of the retina and what was happening in real time with retinal diseases, where before it was just kind of more based on examination techniques, and here we had kind of a definitive test. So part of that, the imaging became a lot better. The treatments, like I said before, became a lot better and more advanced. And I think just I think that sort of spirit of advancement and the wave of technology at the time that I was in residency with respect to retina was such that it was very sort of interesting to me, and I really fell in love with it at the time.
As you were mentioning a little bit earlier about the schools that you went to, from you did an internship at Yale to UVA for med school. Those are not easy programs. How do you feel like those programs and like your career paths has kind of helped you evolve to the doctor that you are today?
Well, I think I've been very fortunate. I think always, having good mentors and having good people you learn from is vital in a field in the field of medicine in particular, and especially in something as sort of specialized as retina and retina surgery and that kind of thing. So I think that has all helped to make me the person that I am today, and I'm very thankful to those people who came before me and helped with my training and so forth. It's very difficult, to be an instructor and a professor, and I'm very very thankful to those who can do that.
That's one of the things you mentioned there from the technology standpoint. Just everything ophthalmology, everything eye seems to that technology just keeps advancing and advancing. How has that been evolving and how has that been going specifically for retina, for macula, for the posterior side? And how are you kind of keeping up with that and how are you bringing that to your patients?
I would say the greatest advancements in the field of retina have been related to the intravitreal drugs, specifically the anti-VEGF drugs that have been developed. And when we first started, uh, there was one generation of drugs, and that has sort of evolved over time. And now we have an armamentarium, I would say, of three or four, drugs that we rely on heavily to treat a lot of these diseases with injections. We also have, implants that have been developed that biodegrade inside the eye. For example, the Ozurdex implant. Just many different pharmacologic advancements have been key. But also, like I said before, imaging. Things that we couldn't document before very well are much easier to document now. We have ultra wide field photography and angiography, and we could even do an OCT out in the periphery of the retina, where before this was something that you could only examine on your own and not really take a picture of or anything or document. And so all these things have sort of made the field easier to navigate, easier to treat patients, has led to better outcomes and more success with treating retina patients.
Do you think it came the being able to get the imaging came first and then that's kind of what's allowed the pharmacological aspect to expand or how did that go?
We would probably still be able to use them, and I think to some degree they were, sort of co-evolving at the time. So it has helped treatment regimens. Now, I'm not sure whether it was one that led to the development of the other, but certainly having them both sort of co-evolve and help with treatment regimens has been wonderful for treatment of retina.
Can you explain to us what is the retina?
The retina is if you compare the eye to a camera, is the photographic film of the camera. So basically, the front of the eye focuses the light onto the retina, and the retina develops the image.
What are all the structures that are in the back part of the eye?
Well, in the back part of the eye, you have the optic nerve, you have the retina, and that's pretty much it for the back part of the eye.
Do you kind of take care of both of those, or do you mostly focus on one or the other?
No, I basically focus, or a retina specialist basically focuses on the retina. The optic nerve is usually the field of either a neuro-ophthalmologist or perhaps a glaucoma specialist if you have glaucoma. But that's basically who deals with the optic nerve, and then the retina is typically the retina specialist.
Within the retina, what would you say are like the 3 to 5 most common conditions that occur that you specifically treat?
The most common conditions in the retina are diabetic retinopathy, macular degeneration, vascular occlusions. Also, you can have retinal detachments. You have retinal tears. You can have macular hole, epiretinal membranes, etc.
The first one you mentioned was diabetic retinopathy. For our listeners, for our patients out there, what does that mean?
Okay, so retinopathy is basically when you have damage to the retina because of incompetence or leakage of blood vessels. And typical things that cause, or the most common thing that causes retinopathy is diabetes. You can also get it from radiation and drug toxicity from different medications. But basically, it's when the blood vessels of the retina are incompetent, leaking, bleeding, etc.
What does the suffix opathy mean, and what is retina, and how does that kind of come together?
So I guess retina is obviously from the retina. Pathy is a state of pathos, or I guess when you have a pathologic condition. Disease of the retina, retinopathy.
So, what is diabetes?
Diabetes is basically something very common, as you may have heard. In the year 2050, there's an estimated 30 million Americans that are going to have diabetes. And basically it's disorder of metabolism where you don't properly your body does not properly assimilate the blood sugar, and there's excess levels of blood sugar running around in your bloodstream. And so over time this elevated blood sugar causes problems such as it glycosylates proteins and cells, and can lead to ultimately death of certain cells that are supportive to blood vessels, such as parasites. And when that happens, you end up, getting retinopathy, like we talked about. You end up getting incompetent vessels, incompetent, leaky blood vessels that can do a number on your retina.
What is the parasite thing? What is that you mentioned there?
Parasites are supportive cells to blood vessels in the retina and elsewhere.
So, how is it that diabetes, a disease of sugar, a disease of insulin, a disease of different things, have such a massive impact on our eye?
Well, it's a global disease, and it affects the microcirculation of different structures. In particular, diabetes is bad for the circulation of your eyes, your kidneys, and your nerves. So you can end up getting retinopathy, nephropathy, and neuropathy. And yeah, the longer you have diabetes, the more likely you are to develop these complications, as well as the control you have of your blood sugar. The better control you have, the less likely you are to develop the complications of diabetes. And the more poorly controlled, the more likely you are.
Does that apply for both type 1 and type 2, or is it in the retinopathy aspect of it?
No, it applies for both type 1 and type 2. There's certain caveats to each disease. For example, type 1 diabetics, upon diagnosis, there's really very little chance of having any retinopathy. And so the first exam after development or diagnosis of type 1 diabetes is supposed to be at 5 years. Whereas if you have type 2 diabetes, this type of diabetes is typically something that has been going on for some time, unnoticed perhaps. And so the recommended first exam is almost immediately after diagnosis of type 2 diabetes.
I love that you brought that up because that was going to be one of my questions. There was, if a patient they get told that they have diabetes, at what point should they come to see you? What is it that that test, that diagnosis? What is it that you guys do here to help them?
First of all, most primary care doctors will send us a patient that gets diagnosed with diabetes, immediately, whether it's type 1 or type 2. And to some degree, I think that's fine. It's very simple. All you need really is a dilated fundus exam, where you dilate the pupils and take a good look at the retina and see if you have any blood or any kind of swelling back there. Uh, and that's very simple to do. And the screenings are really very simple, and should be done yearly after that to make sure you don't have any damage already ongoing.
So, if a patient were to come into the office to get that checkup, what is the process like from the moment they come in to see the front desk and check in to they leave?
Well, for a dilated fundus exam, you basically come in, they'll check your vision, check your pressure. You know, uh, we usually here, since we're retina specialists, we'll take a scan of your retina and macula to make sure you don't have any diabetic macular edema or swelling of the macula. And we might take a picture as well to document. We have ultra wide field imaging. Those are all great, but not really necessary. All you really need is an exam by the doctor to tell you whether you have any diabetes or diabetic retinopathy or not. If you do, then certainly more advanced tests can be done if you have retinopathy or if you have any complications from the retinopathy.
With diabetic
Right.
retinopathy, how important is it for the patients to get tested as soon as possible? Is there stuff that we can do to prevent retinopathy to develop, or is it more of like a condition that, it's happened, now we just have to manage it? How does that work?
Certainly, it's very important to be seen as soon as you're diagnosed with diabetes and check yourself out every year. I think that the sooner you can catch any problem from the diabetes, the better. Sometimes you can be having significant problems and not experiencing visual symptoms, and so it is important to come in and get yourself checked out, whether or not you have visual symptoms on a regular basis, such as yearly, so that we can catch anything early.
Is there any symptoms that the patient may be noticing that they would notice on a day-to-day aspect on that can kind of like help them indicate, hey, I may have this?
Certainly, while it could be completely asymptomatic, you can also have symptoms such as blurred vision. You could have floaters. Those are the main two things: blurred vision, floaters.
What is a
Again,
floater?
so floaters basically are like little. It could be blood in the vitreous, and you can experience it like seeing a little floater or mosquito in your field of vision. It could be also just the jelly of your eye, the vitreous, that can be getting older, coming loose, and can cause floaters as well. So a number of things can cause floaters, but certainly diabetic retinopathy can produce floaters as well.
You've been mentioning the vitreous. What is that? Can you expand a little bit on
Yeah,
that?
the vitreous is the jelly that's inside your eye, and basically you're born with a very thick jello-like substance in your eye that's very sturdy. And as you get older, the vitreous starts becoming more watery, particularly more in the center, and it can collapse on itself and come off the back of the eye. And when it happens, you can have symptoms such as floaters, you can have flashes, you can have like a veil over your vision, a blurred vision, and it's important to get checked out once this happens, because it could lead to retinal tears or retinal detachment. You have to get yourself checked out if you have any of those symptoms. But the vitreous is basically, yeah, the jelly of your eye, which eventually in everybody will deteriorate. It will degenerate and come off the back of the eye.
What age does that start to happen?
Usually around the age of 60.
Okay.
It can be sooner. For example, if you have myopia, myopic patients or nearsighted patients can have a larger eye, and this can lead to the vitreous coming off sooner rather than later.
Well, what about with diabetic retinopathy? Is it an age that once you get to that age, or is it a time under the diabetes condition? How does that work?
Yes. So in diabetes, there's several factors, and the two most important ones are the time that you have diabetes, as well as the control of your blood sugar. By 20 years, about 90 percent of patients will have diabetes, that diabetic retinopathy. So you have to really control, your blood sugar as best as possible, and also blood pressure is also a comorbidity that can influence, the development and severity of diabetic retinopathy. They go kind of hand in hand. So not only do you have to control your blood sugars really well when you have diabetes, in order to um, sort of not develop diabetic retinopathy, but also your blood pressure is very important to maintain under control as well.
The diabetes aspect of it is kind of deteriorating or affecting the integrity of the blood vessel. Is that why having a higher blood pressure, now you're having more pressure kind of go through that pipe when that pipe is no longer strong? Is that what's happening, or is there something else?
Yeah, definitely. Having your blood pressure out of control can lead to more macular edema and just overall, increased vascular damage over time that can play sort of together or in concert with the changes from the retinopathy.
That's interesting. A lot of the conversations that we've been having, what I keep hearing is vascular occlusion, liquids, fluids. It seems to be a lot of blood based, vessels based issues that is kind of affecting the backside, whether it was from like a retinopathy standpoint. Is that kind of the case? Is a lot of these conditions kind of trying to like maintain the integrity of like the blood vessel?
Yes, the retina is a very vascular structure, and a lot of these diseases have a common pathway, which is the VEGF pathway. So what happens is in diabetes, when you have a lack of good circulation, so to speak, because you have compromised blood vessels, your eye senses a need for oxygen. It releases a substance called VEGF, and this VEGF is vascular endothelial growth factor. And in theory, you would think it would work because it senses a lack of oxygen. It wants to create new blood vessels and, sort of get nutrients or oxygen to the retina, so the blood vessels become leaky. So that's what VEGF does. It creates new blood vessels, so angiogenesis. It also makes blood vessels more leaky. But what happens is, even though you think this would work, it doesn't really work well unless this is happening during embryogenesis. So at this stage in life, basically it just creates a situation that's pathologic, and you develop problems from it. The same as with macular degeneration. Macular degeneration, retinal pigment epithelial cells start malfunctioning. They start accumulating debris or byproducts of metabolism, called drusen. There's a sense or lack of oxygen as well. VEGF is then upregulated in your eye. You would think it would work because maybe the retina is sensing a lack of oxygen, but in reality, this signal to create new blood vessels creates these abnormal, leaky, fragile blood vessels as well, and that leads to the complications in macular degeneration. And the same goes for vascular occlusions, be it central retinal vein occlusion or branch retinal vein occlusion. They all basically upregulate VEGF. So it's the common pathway. So a lot of these conditions are vascular. A lot of these conditions are VEGF mediated. And that's why pretty much the same armamentarium of injections works for all these conditions. Those signals, such as the upregulation of VEGF, which are necessary for normal, blood vessel formation during embryogenesis and so forth, is at a later stage, pathologic, and it leads to problems.
You're saying that we have medications that can stop that process from happening?
Correct. So the all of the newer treatments for these conditions in the retina are treated with injections for the most part, and they're all anti-VEGF injections, so they directly counteract the effect of the VEGF.
That's pretty cool.
Yeah, it's incredible, and it has really, really changed the lives of many people. When I started residency, was sort of the naissance, or when you first started looking into this kind of thing. And before that, many people went blind with macular degeneration, for example, or diabetic retinopathy. And the advent of these injections has been nothing but miraculous for a lot of people, and has really changed the way that we treat retinal disease.
I'm sure with, the many years that you've been doing this, is there any patients or any stories that really stand out for you on like how these medications, the way that you've been able to help your patients has like helped and it impacted their lives? Like anything that really stands out to you?
I mean, yeah, I mean, I have countless, patients who have benefited from these treatments. I mean, one person I'm thinking about right now is a physician who developed bleeding, in his macula from wet macular degeneration, and really his vision went from like 2400, which is basically legally blind. Okay, and we started these treatments on his eye, and he's now 2030. So the chance to come back from basically blindness is before these injections was never seen, and or rarely seen, I would say. But now it's something that we see frequently. So it's part of what I like to see in clinic, and what makes my day is to see patients do well, obviously. But who else? There's also, unfortunately, young patients who have had diabetes since they're very young, who at the age, in their 20s are already having, major complications in their eyes from diabetes, and these medications really help them as well. One person I'm thinking about in particular, was basically blind in both eyes from diabetic retinopathy and bleeding inside her eyes, and with the injections as well as surgery and so forth, but with the help of injections as well, has been able to recuperate her vision. And these stories are, we see these miracles on a daily basis, really.
That's got to be so cool because it's vision, seeing, we for sure take for granted because it's like you just wake up and see this beautiful world, but like not being able to do that and to be able to have the skill, have the medication, have the education to be able to impact those lives. It's not just even impacting that individual, but what that individual can now also do. So it's like a trickle down effect of everything that you're doing. It's like I can help this person like see this world, live their life in a completely different way that they wouldn't otherwise. Correct me if I'm wrong, but this doesn't happen overnight.
No, it's definitely a process. And one thing I like to tell my patients, particularly diabetics, it's this is like a freight train that's coming at you, and it's coming full speed. It has taken many years to build up to the speed, and it's going to take time to stop it. It doesn't just, one injection doesn't do the trick. It's several years of treatment, typically for most patients that have some complication from diabetic retinopathy to get better. But the good news is that they do get better, and incredibly so. And I feel very fortunate, humbled, and blessed to be able to do this and to help patients in this way. And I think that we're in a great stage right now, and there's more to come as well.
We've been talking more of the medication aspect of it. It's not just the medication, it's the ability to actually put that medication in the right spot. I saw you do some of your procedures earlier today and it was like watching art. How was that process for you to learn that? How kind of has that evolved? And what do you think kind of makes you such a good doctor from that perspective as well? Obviously with all your years of experience.
Well, thank you for that. But like anything else, it's repetition. It's basically good training. You learn the right way. You implement good, procedures, and you just repeat them over and over again. And you know, it's uh, it's very precise, but at the same time, something you do a lot of. You really get good at it. That's one of the nice things about specialization and about focusing on one particular field. And in many cases, it's the majority of what I do all day is eye injections, and so it's something that I'm very specialized at. It's part of what retina specialists can offer patients is that expertise in treating a certain small amount of diseases that affect a very particular and small space in the eye.
What makes a good retina doctor?
I think someone who is has got the knowledge, has undergone obviously the appropriate training, to say the least, but also somebody who has enough experience that they are slick at doing these procedures already, and to them it's like breathing, day in and day out. you see so many patients, you do this for so long, and you kind of you kind of have a really good feel for what these conditions are, how to diagnose them, the subtle caveats, between the conditions that you can recognize almost immediately that perhaps other doctors cannot. And so, I think also somebody you can relate to, speak to, feel comfortable with.
Well, one of the things I noticed from seeing you interact with your patients was, like you mentioned there, that relationship. The patients I saw, the interaction you have with them, that you guys know each other. Like it's a relationship you guys have built over time, and they're comfortable to ask you certain questions if they felt like they weren't sure about stuff. How have you kind of gotten to that point, or was that just like natural for you? How did that go about?
I think we were talking about this before. Retina, or the field of retina, when I started, was very different. It was more of a surgical based field where you did 2 or 3 days of surgery, and you saw pre-ops and post-ops in clinic, and planned for surgery. And then once surgery was done, you said goodbye and you sent them back to their referring doctor. But more and more, it's become very familiar in clinic, because these treatments, as good as they are and as miraculous as they are, they do have a high burden of treatment, which is that the patient does have to come in on a regular basis, be it once a month, some patients twice a month, sometimes even more than that. So there's a lot of patients that I know personally for years. We know their life stories, we know what's happened to them, we know, we see them more than their primary care doctor, we see them more than their cardiologist, we see them more than any other doctor, just because it's such a high burden of treatment that they have to come in and be seen and be treated, that we get to know them. And I feel that that's been one of the greatest things that I have serendipitously sort of fallen into in my field, is that relationship with the patients, that wasn't really something that was intended at first, but in reality I really enjoy that part of my practice, knowing my patients, knowing them by name when I walk in without even having to look at the chart, and knowing what's wrong with them, and asking them about their family, about their jobs, about their most recent vacation and so forth. And it's a really rewarding part of the practice.
And you know what I found so interesting was the aspect of, you're doing roughly anywhere from 50 to 110, procedures a day. You're able to help so many different patients, but there's still that relationship part, which is like beautiful to see. I think that was like really unique.
Thank you.
How is it really that doing so many procedures like that really like makes you better?
I think, like anything else, it's some of it is just muscle memory from being a good technician, and doing a procedure well. But also there's the familiarity with the diagnoses and the pictures and the way they're supposed to look, and how certain conditions vary slightly in the way they present with the edema on the scan, which you can look at a scan and know right away, whether it's a branch vein occlusion, or whether it's diabetic retinopathy, or something else. But I personally like seeing a lot of patients per day, and seeing patients by volume. Not that I don't like being more sort of individual, and sort of one by one. But I think that you learn as a doctor as well. The more you see, the more you can see, and the more you can diagnose, and the more you're going to run into your interesting cases, and your and things you learn from, the more patients you see as well. So I think for me it's just more interesting. It's also educational for myself, and I think it does bring benefit to the patient to have a good level of comfort with procedures, and the diagnoses of the disease that they're specifically here to see you for.
Let's talk a little bit about retina detachment. What is that?
So retinal detachment, starting off, as we mentioned, the retina is the photographic film of the eye, and it has the consistency of like wet tissue paper, and it lines the back of the eye. The vitreous, or the jelly of the eye, is attached to the retina when you're born, and as you develop, and right around the age of 60, the vitreous starts becoming more watery, and it can pull on the retina, cause a retinal tear, which can cause a retinal detachment. So retinal detachment is an ocular emergency. It can permanently impair your vision if you don't treat it right away successfully. So the symptoms of a retinal detachment are flashes, floaters, a curtain or veil over your vision, decreased vision in general, and there's two states in a retinal detachment that are important to denote whether it's involving the macula or not involving the macula. It's an emergency if it is not involving the macula, because as you can imagine, the macula is the area where you get the highest visual acuity from, the 20/20 vision. And if it involves the macula, it will significantly decrease your chances of seeing well even after repair. But if it hasn't involved the macula yet, it's an emergency, because if we get to it before it involves the macula, then you have a much higher chance of maintaining the vision that you have and avoiding visual loss. Typically, a macula on retinal detachment, meaning the macula is not involved yet, that one has to be done within 24 hours. So, if it's macula off or it has already involved the macula and your vision has suffered from that already, it's an urgency, but not as important to get there in 24 hours. You can do it within 10 days or so. Anytime what's more convenient perhaps to get to the OR for whatever reason, perhaps getting your medical clearances and doing it at a regularly scheduled time with the regular staff. That's basically a little bit about retinal detachment.
So you're saying we have the eyeball, we
Mhm.
have this like sheet of tissue like paper, like you've mentioned in the back. Is the jelly what's kind of keeping the consistency of that eyeball there?
The jelly doesn't really do much during your life. It's just an optically clear sort of structure. It doesn't do much during most of your life, but then when it degenerates, it does cause problems, like we talked about. The degenerating vitreous can cause a posterior vitreous detachment. That's when the jelly comes off the back of the eye, and when it does so, it can, for most people, it just comes off, and you might get some floaters, and they may go away with time and so forth, but it doesn't really cause many problems. But for some people, approximately one in 20,000 people, it can cause like a retinal detachment. So that's the that's sort of the fear, and usually it's within the first 2 months of developing this vitreous detachment. So the vitreous retina interaction is important.
Does this happen to just anybody? Does this happen to like a certain age group? Does this happen because of certain like clinical conditions that they also have?
Yes, kind of all of the above, right? I mean,
Really?
you can have retinal detachments just basically due to diabetes that are a little bit different. There's different types of retinal detachment. So you can have a diabetic tractional retinal detachment, and that's due to obviously developing, diabetic retinopathy and the complication of proliferative diabetic retinopathy, and beyond that, a traction retinal detachment. Then you can have a regmet. It's called regmatogenous retinal detachment. It's a big word, but basically it means that it stems from a retinal tear or retinal defect in your eye, and typically those are caused by that vitreous retina interface interaction, where the jelly will pull off, or the vitreous will pull on the retina too hard and cause a tear. And then that allows that watery substance that was before that formed vitreous to sort of get underneath the retina and detach the retina.
Is it because it's like a neurological structure that it just even if you get it back, like it doesn't matter, it's done?
Yeah, it can be affected. Now, there's always different levels, and I like to tell my patients, having your retina detached is like, severing your spinal cord. Sometimes they can help you, and you might be able to walk, but you won't be able to perhaps run, or be an athlete. It's the same thing. The Once the retina does come off, and the macula is involved, for example, the statistically significant chance of having better than 20/50 vision, goes way down. It's important to try to catch retinal detachments early before they have affected the macula in particular.
So I guess the two big questions there is how do we catch it? How do we treat it?
So catching it, number one is just awareness. Having patients be aware that if they develop, floaters, flashes, a curtain or veil over your vision, definitely it's something that has to be looked at and treated right away versus, waiting on it or sitting on it, or, it's an emergency. So just having the public be aware of that is something important. Sometimes people don't even realize that anything happened to their eye, and they can, since you have both eyes open and one eye, something happens to it. Some people don't even realize that, but the majority of people will have some symptoms, will have, some kind of visual impairment, and the rapidity with which they seek care is very important.
You mentioned different symptoms that the patient may encounter, such as flashing, the curtain in the veil, floaters. Can you break down each one of those?
Trying to look for symptoms of retinal detachment, for example, we mentioned flashes, floaters, curtain or veil. So what the patient might be seeing, say for example, you were to develop a traction on the retina, uh, like the vitreous pulling on the retina. It's a mechanical depolarization of the retinal cells, and you develop, the flash. So that can just mean that the vitreous is pulling on the retina a little too hard. Now, if it pulls too hard, then you can develop a retinal tear. And perhaps when you develop the retinal tear, you might have a little bit of blood come out. For example, the retina has a lot of blood vessels, and sometimes blood comes out, and that could be the floaters that you see as well. And then if you develop a retinal detachment, it could be that curtain or veil that you're seeing. If you see like curtain or veil over your eye, it could be a retinal detachment.
When you're saying curtain and veil, is it part of it? Is it the whole thing? Is it top to bottom? Is it side to side?
I guess it could be from either direction. You could have, an inferior retinal detachment that would give you a superior, field defect, or you could have it on the side and it can give you, it's basically opposite to wherever it's, detaching from. So if you had an inferior retinal detachment, it would give you a superior visual defect.
The fact that you said it was superior be inferior, it's flipped, right? Can you share a little bit about that from like the anatomy of the eye? I
Yeah,
think that's interesting.
yeah, basically it's due to the wiring, of the eye, and the way the light comes in. So from the left be reflected on the right side of your right eye, on the left side of your left eye. Things are backwards and upside down, actually. So as well, sort of the superior world is seen by your inferior retina because that's just where the light focuses, and then basically it's corrected by the wiring inside your optic nerves and so forth. And as it makes its way over to your brain and the occipital cortex, it basically corrects itself, and that's how you end up, with these interesting sort of visual defects because of the way your eye sees the world.
Yeah, I remember the circles with the squares broken down into the quadrants, and it's
Right,
like which way or what. It
right,
tells
right.
you exactly which optic nerve and the crisscross.
Exactly, exactly,
Yeah,
all that
yeah.
stuff. You had asked me whether, certain conditions can predispose you to retinal detachments, for example. And yes, I had mentioned diabetes and so forth, but there's also myopia. If you have a lot of myopia, for example, you are at high risk of developing, like a retinal tear or break or detachment. Myopia is basically nearsightedness, and so a nearsighted eye is typically a larger eye, and the retina is stretched more than in a regular eye, and so it's thinner, and also the vitreous is more easily degenerates and more easily comes off the back of the eye, and it's more likely for you to develop a retinal tear, break, or detachment if you have myopia. So the myopic eye, rather than being shaped like a sphere, is more shaped like a football. It's longer, bigger.
Patients that know that they have myopia, what age, at what time, at what stage of their life should they be really making sure that they're being aware of detachments?
Well, I think if your doctor should make you aware. Certainly, you typically will see an eye care professional if you have a significant myopia, and particularly above the 6 diopters is considered high myopia. At that point, things start changing a little bit, and you are going to have somebody who prescribes your glasses, your contacts, and so your optometric physician can recommend or make aware the patient of they should be seen right away for any symptoms flashes, floaters, curtain or veil, etc. A lot of myopics have a condition called lattice degeneration. And again, that's from the stretching of the retina and the thinning out of the retina in the periphery. And if you have that, it does make you more likely to have a problem with retinal detachment, for example, in the future. And so, any patient that has these conditions should just be made aware by whoever's prescribed. The easiest thing is whoever's prescribing them. Their contacts or glasses can make them aware of the symptoms and so forth. But if they've developed any retinal holes or any kind of other findings, then they should be probably referred to a retina specialist.
So you mentioned their retina holes, and I think I've heard you talk about macular holes and things like that. How is the detachment side different than the hole?
So a retinal hole is basically when the vitreous pulls too hard on the retina and creates a hole. Typically those are more in the periphery of the retina. A lot of retinal holes don't even have to be lasered. They don't pose a great risk to vision or to a great risk to causing retinal detachment. But certainly a tear, which still has traction, does pose a greater risk, and the risk is about 50% will lead to retinal detachment if untreated. So retinal tears are typically almost always lasered. The retinal holes, sometimes depending on the location, their size, and so forth. Uh, Also, if there's any traction, remaining on the hole, and so forth, can be lasered or can be observed. And Macular hole is sort of a hole, but right in the center of the macula. Sometimes the vitreous can pull right at the center of the macula and cause a hole, and that one is particularly visually, symptomatic because it's as we talked about before, the macula is the center of your 20/20 vision. That's where the light focuses directly on, and if you happen to develop a macular hole, you will definitely be experiencing some either distortion of vision or decreased vision or like a missing area of your central vision.
So is it like levels of severity in a way? It's like the detachment then kind of can become the whole.
The retinal hole can always lead to a retinal detachment or a retinal tear. That's a possibility.
Can
Um,
it happen the other way?
well, I mean, a detachment can cause further tears and holes in susceptible areas. Like if your retina is sort of loose and detaching it, you don't typically think of it that way, but yes, it can. Yeah, you can have sometimes multiple holes or tears can develop into like what's called a giant retinal tear and sort of come together and coalesce.
It's just crazy how there's so many different things that can happen in such a small,
Small.
small, like
It's very small. Yeah.
very small. Yeah.
Yeah, everything is in sort of small size, and we operate, with special microscopes, and we have special imaging and so forth, and yeah, it's kind of part of the cool thing about it, for our surgeons is the microsurgery aspect of it is very sort of rewarding, interesting, and I'll say it's fun, but certainly for the patient, it's a good thing that we have these technologies and instrumentation and so forth that we have these days to accomplish these surgeries.
Yeah, and you mentioned some of the things there was the laser side, right? We've heard, at least from my experience, I've heard the lasers on the interior part of the eye and on the posterior part with the retina and the macula. Like, what is it that the lasers do?
Most of the lasers that we do in retina are for retinal tears, for example, where we will laser around a retinal tear or hole or defect so as to create a scar in the retina that will prevent you from detaching the retina. So basically, it's a prophylaxis against retinal detachment when you laser a tear or hole. Additionally, we do lasers for proliferative diabetic retinopathy. There's something called panretinal photocoagulation, and that basically you laser the peripheral retina in the effort of decreasing the VEGF drive of the eye. And so the proliferative diabetic retinopathy improves with lasering of the peripheral retina. Also, we can laser the macula for diabetic macular edema. There's something called focal laser photocoagulation. And that will target little microaneurysms, for example, that are leaking and so forth in the macula and will decrease the swelling in the central aspect of the macula and can help to improve vision and prolong, any kind of visual decline from happening. Uh, and those are basically the main ways that we utilize laser.
You're looking at it from a standpoint of preventative to a stopping. I think that's so cool to see how a laser can just do so much. How has the field from the laser standpoint kind of been evolving in the posterior part of the eye? Is it constantly changing? How has that been going?
To be frank, the laser is already considered like an older treatment, and we're using laser probably less nowadays than we were when I started, residency, for example, because of the injections, right? A lot of times we're using the laser, not for the tears and so forth. Yes, that's still mainstay treatment, but for example, for the diabetic retinopathy and for diabetic macular edema, we're actually having to use it less because of the injections. The injections work so well that a lot of times there's no need for laser. The laser, you're basically lasering precious real estate. So, the retina. So it's better if we can get away with it without the photocoagulation of the retina per se. But, as well, there is that, if you can add it or adjunct the treatment along with the injections, things can improve, further for certain patients. And also, the injections are great, but sometimes how do you stop the injections? It's an ongoing treatment that is kind of like for most patients, it's forever. The lasers a lot of times can help you perhaps wean off injections and allow a patient less treatment burden.
No, I think that's really interesting how it sounds like the lasers were more for stop it from getting worse. But then now we've been able over time in this technology, now we have things that can not necessarily regress it, but kind of help in preventing more stuff.
So the way I like to tell my patients is that I see the injections as a like a fast term treatment. Like it works very quickly for short term, and then you got to keep giving it. Whereas the lasers take a long time to work, but once they work more permanently.
Mm.
So, so I employ still both treatment strategies. One is to get the patient better faster and quickly with the injections, and then over the long term, the lasers I think help me to wean off the injections a little bit easier and give the patient some more lasting, treatment and decrease treatment burden.
Well, I think that's also like the importance of going to a doctor who is doing this often, staying up to date on the new technologies, and the decisions you're making are no joke. It's like so having that experience is so valuable, you know?
Personally, in my own practice, I've noticed, over the years, I tend to sort of I can envision the plan, for the patient in front of my eyes, pretty quickly, and can fine tune things, in a way where perhaps before I wasn't able to. So I think experience always helps any doctor in any field, but certainly, I have noticed it in my practice.
One of the conditions we haven't talked about, macular degeneration. Can you kind of explain what that is?
Macular degeneration is a condition. It's called age-related macular degeneration, and typically above the age of 55, people develop, let's call it a dysfunction of the supporting cells of the retina. Some cells called the retinal pigment epithelium start to, misfunction. They start accumulating byproducts of metabolism. They start dropping out or dying, and so the eye, senses a lack of oxygen, for example, and it upregulates vascular endothelial growth factor or VEGF, and this will lead to growth of new blood vessels that are abnormal. They leak. They're fragile. They can bleed, and so there's two main types, right? There's what's referred to as dry macular degeneration and wet macular degeneration. So the dry macular degeneration, you know, most patients start off with this before they ever, can develop wet macular degeneration for the most part. And so basically, a patient is diagnosed with this, and what we tell them is this can affect your vision, and but it will take a long time. It's very slow progressing, and doesn't really, happen overnight type of thing. But the wet macular degeneration is very feared because it can overnight, rob you of your vision. It can rob you of your vision permanently. If you happen to bleed a lot, or if you don't treat it in time, or so forth. But so for the dry, the mainstay of treatment currently is formulation of antioxidant vitamins, including lutein and zeaxanthin, that are called AREDS 2 formulation vitamins. And these will decrease the risk of progression from dry to wet macular degeneration by 25% over the next, 5 or 10 years. There's also, for a specific type of dry macular degeneration called geographic atrophy, there's also a new injection that just recently came out called Syfovre, and that's supposed to decrease the rate of progression of the geographic atrophy by 20%. So it's also a high burden of treatment, up to one injection every 2 months. There have been some recent reports of inflammation in the eye with this medication, and so a lot of retina specialists are holding back on prescribing this for the time being until more data is available. Also, part of or one of the mainstays of treatment and follow up for dry macular degeneration is the self exam. The patient has to check themselves with an Amsler grid. Basically, it's a grid that you look at, and you can notice more easily if you have any distortion of straight lines, or maybe missing areas, and so forth. And so the patient can themselves come in if they have any changes in their Amsler grid. Uh, so to summarize, dry macular degeneration, mainstay of treatment is vitamins, Air2 formulation vitamins, and the self exam with the Amsler grid. There's new things on the horizon that have recently come out that are exciting, but with a caveat that they have some inflammation is these injections with Syfovre, and we're currently monitoring that situation, as well as then you have the wet macular degeneration, and this is where all the anti-VEGF injections sort of come into play. The mainstay of treatment here are injections with Avastin. We have that's the drug we probably inject the most. It's not really generic, but let's call it the generic version of the anti-VEGF drugs. And then you have Lucentis, you have Eylea, and you have Vabysmo. So all these drugs, with the Vabysmo being the newest one, work very well for the wet macular degeneration. You have about a 40% chance of visual improvement by 3 lines or more with these injections, and you have a 90% chance of maintenance of vision. They are heavy on the treatment burden, like we talked about before. About 90% of patients will have to remain on these injections ongoing. To some degree, we can vary the rate at which the patient obtains these injections and make it better for the patient. But to some degree, they will have to continue to come in, and about 10% of patients can stop for whatever reason. The macular degeneration, the leakage will stop and won't come back, and so forth. And that's really the mainstay of treatment for both wet and the dry.
So, how is it that the patients recognize or acknowledge or know that they may be having macular degeneration?
A lot of times they may, not be getting as good a vision, as they would like with their glasses, for example, and their optometrist or their general ophthalmologist might notice that they have macular degeneration and will refer them in for an evaluation and possible treatment.
You were mentioning the grid. I have family members who have had macular degeneration, and one of the exercises that they were told to do is to look at a clock. Is that what you're talking about, or is that different?
No, it's a little bit different. This is more like a grid, like almost like graph paper when
Okay.
you were in school. You're supposed to look at the center of it, and it'll be easier to tell there whether lines are being distorted there or not.
If I'm struggling with my eye health, what are some things that I should stop doing?
Well, I think it's very important to stop smoking if you smoke. Additionally, if you can avoid obesity, that would be ideal. And also avoid excess alcohol. Those three things I think are key.
What are some things that I should be doing? What are some things that can help my eye health?
I think anything that's good for your heart overall is good for your eyes. But in particular, eating lots of green leafy vegetables, eating also fruits with lots of dark pigments like raspberries, blueberries that are heavy in antioxidants are good for your eyes as well. And just anything in general that's good for your vascular health and tone, like exercise, would also be recommended.
And you've mentioned that from both when not to do something and when to do something, you've mentioned vascular health. Why is our heart and our vascular health so important for our vision health?
Well, a lot of the systemic, conditions that lead to, vascular disease lead to retinal, issues because of their vascular issues, like diabetes, also, vascular occlusions, and so forth are directly relatable to, our overall health.